Okay. Good morning, everyone. My name is Stefan Pagliuzzo, and I'm the Central South Regional Stroke Program Director. I want to welcome you to today's Coder and Health Information Managers Stroke Education Workshop. We've designed a day that we hope has a great deal of content you'll find very helpful and very useful in your roles moving forward. We intend this to be a very full morning, but also lots of fun. So we're excited about today's workshop, and thank you all so much for attending. This is the agenda you would have all received for today's event. As you can see, we hope to cover a few major topics over the course of the morning. I'll present you an overview of the Central South Regional Stroke Network. After that, Ellie Wisniewski and I will speak a little bit about data and how it informs and drives funding and stroke best practice implementation, which directly impacts patient care and helps achieve better patient outcomes. Rhonda will then speak about how patients in our region get access to life-saving endovascular therapy, sometimes called EVT or sometimes called clot retrieval therapy. We'll then take a short break before Carla and Heather will review CHI Special Projects 340, 640, and 740. And we will spend some time reviewing resources to support and some strategies to support improved CHI Special Project data quality. And then finally, Rhonda will speak to some exciting future directions in stroke care and what to watch out for in the coming months and years. I do want to take a minute here to say thank you to the Planning Committee, Rhonda McNichol-Whiteman, Heather Corrigan, Carla Ariema, and Ellie Wisniewski. Amazing job pulling this day together. Again, a lot of great content. Very excited about being able to present this to the entire region, and we intend it to be a very helpful and useful day. So thank you so much to the Planning Committee. Okay, so as I mentioned at the beginning, you are aware that this workshop is being recorded. The Central South Regional Stroke Network has a website. It's at www.csnstroke.ca. Rhonda, if you are okay to maybe write that into the chat, so the website, that would be great. On the website, we post all the recordings of our webinars and workshops so that those who are not able to attend our events are able to watch it on their own time at a later date. And also it can be used as a resource to go back and review maybe something that you missed or something that you want to highlight again. If you go to our site into the healthcare professionals section, you'll be able to actually scroll down and you'll see a title that says past educational events and resources. And that's where you'll find this. In the coming days, this will be posted on the site. We encourage you, again, not only to use this as a resource in the future for yourselves, but please share this resource with any of your colleagues who are not able to attend today's workshop and who you think would benefit from the information presented. Also important to note, in the coming days, or actually shortly after the event, we'll send out a link to the evaluation, and then after that, when this is posted online, we'll send out a link to the video being posted online. Rhonda also wanted me to mention, for those who didn't receive the case studies, you can reach out to Rhonda by email and she can send them. Okay, so just a bit of housekeeping here before we start the day. With regards to Zoom, we do ask that you please keep your microphone muted unless asking a question. There will be time built into the presentations today to ask questions. The workshop, as I mentioned, is being recorded and posted on the website. So if you don't wish to be on the recording, please turn your camera off. And actually, if you have a picture that is your camera off screen, if you take that picture away, then it won't be on the recording as well. So just for those who do not want to be on camera on the recording when we post it on the website, please keep your cameras off. Okay, and without further ado, I think we're going to jump into the agenda for today. Any questions or concerns before we get started? Okay, wonderful. So I will start today with a little bit of a background on the provincial and regional organization of stroke care. So the objectives for this section of the agenda are really as follows. I'm going to take some time to describe that structure of stroke care and best practice implementation, provide a high-level review of some regional models we have that impact stroke care. This includes some of our hyperacute stroke models, our bypass models, Telestroke, what it is and how it's used, acute stroke unit access, and then make you aware of the stroke rehabilitation sites within our region. And then at the end, leave a few minutes for questions and discussion. So in about the year 2000, the Ontario stroke system was developed. And so the Ontario stroke system is really a series of regional networks that emphasize best practice implementation across the province. So you can see here on the map, there are 11 regional stroke networks. Each of them have and district stroke centers. The regional and district stroke centers within each region are really required to meet best practice or gold standard stroke care guidelines. Those sites have a designated role in organizing human and medical resources for the region and really developing a plan for best practice implementation across their entire region and across their entire continuum of care. And so bringing it down to our region, this is the entire Central South region. And so our region consists of what was previously named LHINs 3 and 4, or the Waterloo-Wellington LHIN and the H&HB LHIN, now both part of the Ontario West region. And within our region, we have many, many teams that work every day to deliver best practice to those who are affected by stroke. So just orienting you to the map, highlighted in black and red, you can see the Hamilton General Hospital as the regional stroke center. You can also see our 3 district stroke centers, and the district stroke centers in our region are the Greater Niagara General Hospital, the Brantford General Hospital, and Grand River Hospital. In addition, in our region, we have 2 additional TPA delivery sites, and those are at the Guelph General Hospital and Joseph Brant Hospital. I'll get into some more of the detail in some following slides, but there are 6 acute stroke units in our region, along with 7 stroke rehabilitation sites. And really, as a regional network, we work with all 22 hospitals within our region and other organizations as well to drive best practice stroke care to improve outcomes for persons with stroke. So if I was to summarize the mandate of the Regional Stroke Network in a sentence, it's really to facilitate the implementation of stroke best practices across the entire continuum of care, across the entire geography of the Central South region. This includes from public awareness through the entire continuum of care to community reintegration. And this is our team that facilitates this. Really, it's working with all of the stakeholders across the region to work together and collaboratively to drive this best practice. So the following slide, I think, will be helpful in visualizing the stroke access within the Central South region. As you can see on this map, I've circled the centers who provide hyperacute stroke therapy. So that's TPA and/or EVT. So within our region, as mentioned, we have 6 TPA delivery centers. TPA is delivered at Hospital, Guelph General Hospital, Brantford General Hospital, Joseph Brant Hospital, the Greater Niagara General Hospital, and the Hamilton General Hospital. The Hamilton General is the only EVT center, clot retrieval center, or it's sometimes called endovascular therapy center, all within our region. And I apologize if I use those, but they're kind of interchangeable. EVT, clot retrieval, endovascular therapy, they're all meaning the same thing. So within our region, because the Hamilton General is the EVT center, every case for EVT from all of our regional hospitals are transferred to the Hamilton General Hospital for EVT. Okay. One of the things we thought would be helpful to highlight here was bypass models and how that works. Why are sometimes hospitals bypassed so patients get to other hospitals? In the first 6 hours after stroke, the paramedics will bypass non-stroke hospitals to bring a patient to a hyperacute stroke center. This is the actual acute stroke bypass protocol. If a patient presents with a new onset of at least one symptom suggestive of the onset of acute stroke. And really it follows the FAST signs of stroke: unilateral weakness in the arm or leg, slurred speech or inappropriate words or mute, unilateral face drooping. If any of these symptoms are suggestive of stroke and the onset of symptoms is clearly determined, the patient can be transported to arrive at a designated stroke center within 6 hours of the time of symptom onset, or the time that the patient was last seen in usual state of health. So really within that first 6 hours, the paramedics are going to bypass other hospitals to make sure patients get to a stroke center where they can be evaluated and potentially treated in that hyperacute window. So an example might be, in our region, might be Dunnville. If a patient's picked up in Dunnville by paramedics and is determined to be within that 0 to 6 hour window of stroke symptom onset, the paramedics will actually bypass the Haldeman War Memorial Hospital in Dunnville and transport the patient directly to the Hamilton General Hospital for hyperacute stroke workup and treatment. And this map is meant to really grossly show the patterns of transport for patients who are within the 0 to 6 hour stroke window. You can see that non-stroke hospitals are clearly bypassed to get to designated stroke centers for immediate hyperacute workup and treatment. So there's a few examples you can see by looking at this map. One example might be Norfolk. You can see with the arrow here, as I'm highlighting on my screen, if a patient is picked up within the window in Simcoe, again, the paramedics bypass Norfolk General Hospital and bring the patient directly to the Brantford General Hospital. Or if someone is picked up in Cambridge, they are bypassing Cambridge Hospital and go directly to the Grand River Hospital. Again, this is within those first 6 hours of stroke symptom onset to get to a stroke center that can treat them hyperacutely. Okay, the next thing to highlight here is Telestroke. And so Telestroke is really an incredible system, and I'm sure you see it often in your coding and abstracting of charts. It's an incredible system that allows centers without stroke neurologists to access stroke neurologists on call 24 hours a day, 7 days a week for hyperacute stroke contact. And these are some older slides, but this diagram is meant to show the connection between a remote or community ED, emergency department, via a secure video conference with a stroke neurologist who's able to quickly come online, virtually assess the patient, review images, and facilitate decision-making regarding the delivery of TPA and or referring the patient to the nearest EVT center for EVT. So this obviously has some very clear benefits. One of these is that included in this are that this allows access to experts despite any distance. So across Ontario, no matter how far a hospital is from a stroke neurologist's office, you can access that expertise in the decision-making in this hyperacute window. This also decreases the needs for patients transferring to another hospital center and then losing time before treatment can begin. So you can imagine if someone is at a center without a stroke neurologist and they need to travel hours to get to that stroke neurologist, we're starting to lose that opportunity to treat these patients in the hyperacute window. And in stroke care, as we know, every second counts. Every minute lost in a stroke is equivalent to losing 1.9 million brain cells. So we want to get patients treated as quickly as possible, and Telestroke really helps this. So this is, again, the map of our region. And what I've tried to highlight here are the Telestroke sites. So those sites circled in red, Brantford General Hospital, Joseph Brant, Guelph General Hospital, those are all 24/7 users of Telestroke. The hospitals circled in purple are centers that use Telestroke PRN or as needed, and those are the Grand River Hospital and Greater Niagara General Hospital. So currently, to note, and this is certainly something with today's audience we wanted to highlight, the province is focusing on a bit of a data gap between the number of Telestroke activations reported at a site level and those reported at a provincial level. They're noticing that there's, in some centers, a relatively significant gap in those two data points. And so this is something the province is trying to better understand at this point to get us a really great sense of the utilization of Telestroke and understanding its impact. And so Yeah, you may hear more about this as our day goes on, or in other conversations about this data quality issue with regards to understanding the true number of activations and utilizations of Telestroke. Okay. I'll spend just a minute or two on our regional EBT access model. We'll be talking a lot about EBT through the day. So EBT referrals primarily go from our TPA centers to the Hamilton General Hospital. The system that is currently built in our region has patients who may be potential candidates for EBT get to their closest stroke center as soon as possible, where they can be further evaluated for potential endovascular therapy, and then referred directly to the Hamilton General Hospital. Very rarely does a non-stroke center send a patient directly to the Hamilton General for endovascular. Currently in the Central South region, we're evaluating different models of access, what that can look like. And right now we're really trying to evaluate the utilization of tools by our paramedics to try and better predict patients who need EBT. We're looking at the volumes of patients across different geographies within our region to figure out if we can optimize this model in any way moving forward. But right now, that is the model that generally occurs. And so this is, again, transferring from our TPA centers and hyperacute stroke centers to the Hamilton General Hospital for endovascular therapy. And so there's a bit of a difference between the early and late window. And so I wanted to highlight this in a chart format to make it relatively straightforward, because I think you'll see that more and more often in charts. Patient arrived 0 to 6 hours in the early window, or patient arrived in the late window. And it's important to note that the late window is now an opportunity for some patients who qualify based upon their imaging and their potential for successful endovascular therapy in the expanded window. EBT can be offered again in the 6 to 24-hour window, again, once the patient has been through a rigorous assessment and through diagnostic imaging when it's appropriate and safe for them. So if a patient's found to have a stroke in the early window, 0 to 6 hours, again, referring back to the bypass protocol we talked about earlier, the paramedics will actually use that to get a patient to a stroke center as quickly as possible. Once there, the patient will have an imaging protocol that includes a CT scan and a multi-phase CTA. In the expanded window, so moving to the right side of the screen here of 6 to 24 hours, a patient is brought very quickly to their nearest hospital. We've worked with all the hospitals in our region so that they can do appropriate assessments and recognize potential expanded window EVT candidates. They would then link with their nearest stroke center and get eligible patients there as quickly as possible. Once at a stroke center, the patient will undergo a different imaging protocol of a CT and CT perfusion and a CTA. This protocol will also include the utilization of something called Rapid software. Rapid is an automated software that can actually determine if a patient's brain has a great deal of savable tissue during the stroke. And if they have a great amount of tissue that can be salvaged and saved, they would therefore do well potentially with endovascular therapy in that expanded window. This technology is a true game changer and one in which we've implemented across our hyperacute stroke centers in Central South Ontario. Okay, and very quickly, these last two sections, just wanted to show everyone where all of the acute stroke units are in our region. Much of the foundation of the work we do starts with getting patients to be treated on a dedicated stroke unit. We know that that treatment is very effective. Just by being treated on a unit that is completely dedicated to stroke care, we can reduce morbidity and mortality and improve the chances of patients going home after stroke. So you can see here, these are all of the acute stroke centers, acute stroke units within our region. We've developed models, and you can see on this slide here, where if patients show up at other hospitals or even are admitted at other hospitals, they can then be transferred very quickly to an acute stroke unit to initiate their care and get them treated for their stroke and moving forward in the pathway as quickly as possible. And we highlight that because, again, you might see patients within the charts moving from hospital to hospital, and after a day moving from one hospital, or within hours moving from one ED to another hospital. This is trying to get patients to the best resource possible for their care. And then very lastly here, wanted to highlight where the stroke rehabilitation sites are within our region. And for some reason, it is not showing up. Oh, there we go. And so this is where all the stroke rehabilitation sites are. We have 7 sites offering stroke rehabilitation within our region. Freeport Hospital, Cambridge Hospital, St. Joe's in Guelph, Hotel Dieu Shaver, the Regional Rehab Center in Hamilton, Joseph Brant, and Brantford General Hospital. Both of the last 2 have integrated units where there's actually acute stroke care and stroke rehabilitative care on the same unit. So I apologize for running it through so quickly, but wanted to share with you so many of our great models we have across our region and help you understand where patients are going and for what reason, what treatment, and getting them there as quickly as possible. Rhonda, I think you sent me a message a couple minutes ago saying I had 3 minutes about 2 minutes ago, so there might be time for one question before moving us on.
Yes, one question.
Any questions with regards to that? Yes, yep, please.
Stefan, I recall at one of the previous things that you did, was there not the ability for the ambulance people to ever give the TPA? Wasn't that, no? No,
not yet. No, there's research being done, but this is certainly not something that is available within our area.
Okay, okay.
And actually, maybe, I don't know, Rhonda, if you talk about it in the last part of the day about future directions in stroke care, but there's talk about different types of medications being delivered, and we don't know where that will go, but absolutely not. Right now, there is no delivery of TPA by the paramedics.
Okay,
great question.
Thank you.
They need a CT scan. So unless it was a stroke ambulance that had a CT scan that could do it, we would never give TPA without having a CT scan. So we may have talked in the past about sort of future directions, and that some jurisdictions, more so in the US, we have some in few in Canada where they have a CT scan, they're able to do stroke and then determine, but without a CT scan, we would never give TPA.
Okay, thank you. Thank you.
Really great question. Really great question. Okay, we'll move along now to keep us on track with our agenda. And I will happily hand this over to Ellie, who's going to start our discussion on how data really drives best practice and funding within our region and beyond. Ellie?
Okay, great. Thanks, Steph. That was wonderful. So hi, everybody. My name is Ellie. I'm the manager of coding and data quality here at Hamilton Health Sciences. So I just want to go through some of the funding formulas and how the coding is used to drive best practice across the province. Next slide, Steph. Next one. Great. So the health services funding reform, we get a lot of funding envelopes. We always have sort of that global bucket of money that the Ministry of Health, Ontario only, because it's provincially funded. They give us a big bucket of money every year, about $1.5 billion at Hamilton Health Sciences for all of our programs. So that's for base funding. We get funding from priority programs, waitlist funding, Cancer Care Ontario, and then some one-time recurring funding. And we also get some funding maybe for some capital projects, etc. Next one. So what the Ministry of Health, they started to move away from the global funding. That was the historical approach for funding. They said, you know, we give you all this money, but we don't have a clue how you spend it, what kind of patients you deliver the care to. So we're going to move to what's called a health system funding reform. So that will be very specific funding that will be delivered. We want to know the number of patients you see, what types of services you delivered, and what kind of evidence you were using to deliver best practice and the care and the needs of the population, especially if the population is growing, say like in Brampton or other areas of growth across the province. Next slide. So health system funding reform, this came in a while ago. And what they said is we'll still keep some global funding, probably about 30%. We'll leave it because it'll sort of go through and fund those very generic delivery care models. But we're going to take 70% of your global funding budget and we're going to make it patient focused. So there's a lot of accountability here for the hospitals. And what they said is we'll use HBAM allocation methodology. So that uses 2-year-old CHI coded data as funding rates. But we're also going to carve out and develop new procedures called quality-based procedures. And that is about 30% of our funding bucket. They will be very specific, and it will be in-year real-time funding. And that is actually all of the stroke model of care. HBAM, it's going to be interesting this year because COVID was 2019. So what they're going to do with all that data that doesn't look like any other year, they may in fact go back one more year for the HBAM funding and say that was a more predictable model of care that you delivered at Hamilton Health Sciences or Greater Niagara or wherever you are in our province. Next slide, please. So coding here is a strategic asset at Hamilton Health Sciences. I'm going to say it again. Coding is a strategic asset at Hamilton Health Sciences. You coders out there, my lovely CHIMs, I've got 35 myself, you are the only ones who tell the patient's story to the Ministry of Health, because what you do, you take the clinical documentation and you convert it into standardized codes following the Canadian standards for coding. You look at all the e-queries, you've got the folio or 3M product, whatever you're using. It is hugely important to all the funding methodologies. The Ministry of Health doesn't get our clinical charts. They wouldn't know how to read them. Half the time we can't read them. So what they get is the clinical codes that you convert. So what happens, and you see it in your WinRx application or your 3M, you put in the codes and it delivers a resource intensity weight, or for some of us who have the HIG grouper, you get a HIG weight. That's the hospital inpatient grouping weights. So how sick is my patient relative to other patients with that same diagnosis, with that same procedure? The Ministry of Health uses the HIG methodology in their funding formula. Okay, it's still CHI, but they have their own little different funding formula. Next slide, please. So this is a big HBAM methodology. On the left, you will see that big bucket that says CHI. That's where they use all the weighted cases. This is our coded data that the Ministry of Health uses. We've got data in NACRS. We've got the ER weighted case. Yes, they do get a weighted case. It's tiny because it's compared to an inpatient. We have the RUGs for NRS, that's your rehab, complex care, OMERS, all of those go into this big hopper. Then we take all of our trial balance on the right-hand side. That's our actual expenses. What did we actually spend to treat all these patients? Goes into the hopper. HBAM does the methodology. It takes in some effects of teaching, geography, ruralness, things like that. And they deliver an expected weighted case for us and expected unit costs. So the Ministry of Health is trying to drive standardized best practice. They take all of the Ontario hospital monies and how we spent it and relate it to our case costing data. That's our CHI and my actual costs. And they say, this is what I would expect you to have for a stroke patient. Next one, please. So HBAM, they look at our actual cost per weighted case. That may not be what we get though. Remember, they don't always fund us for everything we spend because they don't have that much money, okay? So they look at what we actually spent and they compare us and they will take and deliver what the average cost for that stroke patient should be. It's only direct costs. We don't pay for physicians. We don't pay for lighting or anything like that. And they look at our expected costs. So if our expected costs is actually lower than, is higher than our actual, we actually make a little bit of money on the funding formula, believe it or not. So they look at our expected service. We do get a teaching factor here because we have residents and interns. We also have a tertiaryness. We have a really high RAW here at Hamilton, especially at the general site. And distance factors like the hospitals up in the north, they will actually get a little bit more money because it costs more to deliver care because the critical mass isn't there. Okay, next one, please. Quality-based funding, in-year funding. This is really important. Price times volume. So the ministry says if you're a stroke patient, you should cost the same regardless where you are for that delivery of care. It's going to use best practice, clinical pathways, and it really wants to reduce the practice variation across all of the hospitals. We've been doing this since fiscal 2015. Next one, please. So this is all your coding. This is the clinical handbooks. If you haven't seen them, go and ask your decision support people. Strokes, hemorrhagics are actually non-surgical. Okay, so that's what they're funding in the QBP funding. Ischemics and the TIAs, they each get different funding rates. And then Steph, you're talking about the endovascular treatment. They're the only surgical QBP that we monitor here at HHS that the ministry is funding. There's all your codes that you code for diagnosis. That's what the ministry used. There's inclusion, exclusion criteria, adults only, Ontario residents, etc. Next one, please. I think this is my last slide. Thanks, Rhonda, for the heads up. So this is what actually decision support and finance does from a monthly reconciliation report. So we know this is our base funding, not actual dollars, but I'm just giving you an example. So they're saying, you know, those clot retrievals, $30,000 a case. We will give you a budgeted volume every year, and we're going to track to see how close you are and how we're going to monitor that from your coded data. Okay. So in the bottom table on the right is a funding clawback. So if we actually don't see as many patients, say in a clot retrieval, and we're actually less than, we actually have to give money back to the Ministry of Health because they're only going to fund what we actually delivered. They may net it across some of the groupings, but that's how they actually monitor each bucket separately. So your coding is imperative. We don't code for dollars. Don't get my message wrong here. We don't code for dollars. Make sure you're filling out those projects. They're mandated. And this is how the Ministry of Health is using the data to monitor and then predict our care. Okay. Does anybody have any questions?
That was fantastic, Ellie. So maybe I'll jump in here and then we can circle back with maybe an extra minute or two at the end for any questions. But I think that's a really great demonstration of how important the coding is when it comes to the funding and functioning of all of our hospitals. And so now I'm going to turn a little bit and talk a little bit about how important the data is to quality improvement and relate that to how this really leads to better patient outcomes after a stroke, which is obviously what we're all here for. We're all trying to improve, how patients recover, and if at all possible, preventing strokes from happening at all. So that's what I'll do in the next few slides here, reviewing the impact of data on quality improvement within our region, how some of the data is utilized in some larger projects. So looking at Accreditation Canada and the Stroke Distinction Project, how Ontario Health and Core Health use the data from a quality standpoint for each organization in the province, and then bring it down to regionally how we use the data to do some just-in-time work, share strategies, and again, improve care. And then talk very quickly at the end about a couple of provincial data components that they're really focused on right now, looking at stroke symptom onset and alpha FIM. Okay, so the process for quality improvement strategies regionally in Central South, really all of them begin with an analysis of the current state, and that requires fulsome, accurate data. Everything we do, when we know there's a problem, it's because of the data we're seeing. And so what we do is we evaluate the quality improvement strategies utilizing that data to ensure that any quality improvement project that we implement is successful and has the right impact on patient care that we're hoping for. So all quality improvement really begins and ends with the need for accurate data. And because we have this accurate data, we're able to develop projects and best practice implementations that directly impact patient care. And so really this process begins and ends with good quality data and an analysis of that data. Some examples of this are Stroke Distinction Canada, or Stroke Distinction, which is through Accreditation Canada. So just an example here, in November of 2019, Hamilton Health Sciences had their third site visit for Stroke Distinction accreditation, and they achieved Stroke Distinction, which is the highest level of accreditation that you can get in stroke care for both acute and rehabilitation. And to be prepared for stroke distinction, this required a great deal of preparation, preparing the staff for the survey, but also working on quality improvement initiatives to make sure that all of the processes and strategies that will be evaluated by Accreditation Canada are working very well and achieving exactly what we want to do. So a lot of data went into assessing where we currently are and where we needed to get to. Accreditation Canada not only looks at practices inside the walls of the general hospital in Hamilton, but also at regional partners and how we work with all of the sites within our region. And again, data and connections between all of our sites, incredibly important there. So very happy to say, as many of you online know, that Hamilton Health Sciences did achieve stroke distinction in 2019 for both acute and rehabilitation. And a lot of that accreditation process was built on good quality data to allow us to understand where we were and where we needed to go and how we needed to maintain that. And so in the spirit of maintaining it, data really is an essential component of this. And so we are consistently required to submit data to Accreditation Canada to ensure that we're maintaining the standards of stroke distinction. And so those data points are collected very regularly and submitted to accreditation every 6 months. So data really is the foundation of where we needed to go, but also our maintenance and sustaining of those really great processes that were put in place, which is really key to better patient outcomes, is implementing a best practice quality achievement and then sustaining that. Another example of the utilization of data, this is from a provincial lens, is the Core Health Annual Stroke Report. This is a report that is released each June, and it really highlights stroke performance metrics across the continuum of care at a provincial level, at a LIN level, and then even down to an organizational level. As a regional stroke network, we develop organizational specific resources based on the raw data that is disseminated to the regional programs via Core Health. And Core Health is pulling all that data from all of our systems at all of our centers across the province. So again, good key data, quality data going in allows Core Health to pull this data and then send it out across the province. So as a regional network, we then take that data, we establish a meeting schedule with all stroke organizations across the Central South region. We review in detail stroke performance across the continuum of care with each organization, summarize successes and also opportunities for improvement. And this facilitates establishing stroke priorities for the upcoming year. We provide, based on this data, we provide each organization with a multitude of resources that they can utilize to share with their frontline staff. And we encourage each organization to celebrate their successes and discuss opportunities for improvement. Again, the data pulled and disseminated by Core Health to the regions facilitates that priority setting in each organization in the region, and again, leads to better patient care through these quality projects. Okay, within the Central South region, we have a committee that looks specifically at stroke performance metrics on a quarterly basis. And it's called the Regional Stroke Monitoring and Evaluation Committee. This committee looks at indicators across the continuum of care, inclusive of hyperacute through to community stroke rehabilitation and long-term care admissions. This meeting is really utilized to determine key successes regarding stroke performance in the region, so that those centers that have those key successes can share their strategies for success. And then those strategies can be taken up by other hospitals within the region. Just as well, poor performance on the report card often stimulates regional discussion on how to improve those metrics, and again, in turn, improve patient outcomes after stroke. This is an incredibly important table to our quality improvement and best practice implementation within our region. And this is actually the report that we utilized at RSMEC, and we use a really clear red, yellow, green component in order to determine performance that needs improvement, good performance, and exemplary performance. And really this drives the committee and quality comes out of it. So those are a few examples of how we utilize data to drive quality improvement strategies. Maybe just to finish up here, and I think I've got less than a minute, I'll just highlight a couple of areas of provincial focus on data currently. So stroke symptom onset and alpha FIM completion, there's real focus on accurate capture of these two data points. The analysis of the proportion of missing stroke symptom onset cases and the proportion of unknown or missing alpha completion at each acute site is underway in the province. It's important to note that, so when it comes to stroke symptom onset, it's important to note that time is brain. We talked a little bit about this earlier. Every minute in a stroke, 1.9 million brain cells are lost. The province is better trying to understand what time frames patients fall into to when they get the treatments, to when they get to the hospital. And it's starting to look at outcomes in the expanded window that we talked about earlier. So this drives the need for stroke symptom onset to be accurate, to understand outcomes, to understand equitable access, which is a key indicator for core health. The other area of provincial focus is the completion of the alpha FIM. And so the alpha FIM is meant to be completed on or as close to day 3. And what the alpha FIM does, it's an assessment tool that gives the guidelines of the stroke severity that the patient has had, helps determine the type of rehab that they'll need, and really helps triage those cases and allows them to drive forward. This allows the province to better understand the need for rehabilitation within the province and invest appropriately in that moving forward. It helps leverage to help determine what type of rehab that patients will require and where this can be addressed as a province. So really, really important to capture alpha FIM being completed. It is a mandated tool, but very helpful at a local level in triaging a patient and helping them in their stroke journey, and important at a provincial level to understanding the impact and severity of stroke and better planning for rehabilitation needs moving forward. So that was a whirlwind of information for the first 40 minutes of today's event. I think we might have a minute or two here for a couple of questions, and then we'll be handing it off to Rhonda. Any questions? How data drives funding and best practice quality improvement?
Steph, no question, but just to comment, all of those indicators, where we pull that data is from those high special projects. So really the coding of that by our CHIM team is essential with that and informing it as we move forward. Great point, Rhonda. Great point. If we don't have any questions right now, maybe we can move on in the agenda, but if something comes up, please feel free to put it into the chat, or we can address it later on as well. So I think, Rhonda, I'm handing it off to you now. So what I'm going to do is talk a little bit about giving a bit of a review of sort of neuroanatomy physiology. Again, just a very brief high-level overview, but also then to describe some of the scenarios that patients transfer across, and really what do we see with the implementation on that on practice. What you will see with the presentations when they're posted is I've included a number of sort of pictorials and reference slides at the end to give a bit more anatomy and physiology. So when we look at TIA, this is a neurological deficit that resolves in less than 24 hours. What we do know, though, is about 75% of those will resolve within an hour and 90% within 4 hours. Most patients, it is a clear warning sign that a stroke may occur. And what you'll see is the majority of patients, I'm not sure why this is doing this, sorry. Hold on. Hold on, I'll just pause for a minute. Is that better?
Mhm.
Okay, sorry about that. And so what we do know is most TIA patients wouldn't be admitted to hospital. The majority, if they're non-high risk, should be discharged home with referral to stroke prevention clinic. You may see some patients that move forward that are admitted for high risk, and I'll talk a little bit more about that. So again, just to do a sort of a quick review, we know there are the two main types of stroke, the hemorrhagic stroke, or in my plumbing analogy, a burst pipe due to weakening of the walls of the artery. Those are about 15% of the strokes we see. The largest majorities you will see of the strokes and of the charts you're quoting are ischemic strokes, which is with blood supplies cut off to the brain, either with a thrombus or a clot. Or an embolus. Often you'll see thrombus used by the physicians, and really what that means is there is a clot. Just high level to break down a bit of some of the etiologies that we look at with strokes. About 20% of our strokes, or our most common, are related to atherothrombotic or atherosclerotic cerebral vascular disease. You may see ICAD that our physicians are using. This is the leading cause of stroke that we will see. It's related to extra and intracranial stenosis, often due to risk factors, diabetes, hyperlipidemia, sedentary lifestyle, smoking. Some of our mechanisms that we might see are artery to artery embolus within the brain, a small perforator disease that cuts off blood supply. You may also see a dissection that causes blood supply, or vasculitis, which is an inflammation. About 25% of our strokes are lacunar or small vessel disease. You'll often see the physicians using that. What that means is of our cerebral arteries in the brain, there are small arteries that come off to supply areas deep within the brain. You have small clots that are affecting those small perforators. About 20% of our strokes are cardioembolic. Again, I go back to my sort of pumps pipe fluid. This is a problem with the pump, often due to atrial fibrillation, maybe due to heart dilated cardiomyopathy, maybe due to a patent form in ovale, endocarditis. We sometimes see young patients who have IV drug use that have an infected endocarditis, but certainly patients can just have bacterial endocarditis. They may have a clot in their left ventricular, or they may have an aortic artery plaque. About 30% of strokes, they just are not able to identify the cause. This is after an extensive workup. They may do multiple investigations, multiple prolonged monitoring, but it's likely related to an undiagnosed cardioembolic event, likely due to paroxysmal atrial fib that comes and goes that they're not able to identify, or it may be due to an emboli through the patent form in ovale. Sometimes it may be due to a prothrombotic state related to a malignancy. And then last we look at are about 5% of strokes. So these are the less common, but certainly strokes that you do see. So certainly we can see strokes related to venous thromboembolism, watershed strokes, so due to hypoperfusion related to either a myocardial infarction, shock, cardiac surgery. We are also seeing hypercoagulable states. So again, if we look at my analogy, this is a problem with the blood. So again, this can be either due to a hereditary disease. So some patients may have a hereditary problem which makes the blood clot more, often may be able to due to an acquired condition where causes clots to develop in the arteries or both. What we sometimes see here is major surgery, traumas, malignancies. We're seeing a lot more where sometimes the first time we identify the patient has a malignancy is that they've had a stroke. Also, we're seeing COVID because of the prothrombotic state. We're seeing patients who may come in with the stroke. We also find out that they have COVID. There's quite a link related to COVID and stroke. So there are a number of conditions that can make the patient prothrombotic, certainly nephrotic syndromes that we may see as we're going. So then if we move on to large vessel strokes. So these are our most severe types of strokes because they restrict blood supply to a large portion of the brain, causing severe stroke deficits and severe disability. What we look at when we refer to an LVO stroke by our physicians is a stroke affecting the internal carotid artery, the middle cerebral artery. So you may see the physician refer to the M1 branch or the M2 branch of LVO, or the basilar arteries. When we look at treatments for stroke, we've talked a little bit, we know that patients may get thrombolysis that has, again, we're seeing primarily TPA currently, but we know we may see that change. Again, there is a time period for that for 4.5 hours, and Steph has talked about the sites that provide it. We talked about endovascular treatment. Patients may get that if they're eligible for TPA or if they have contraindications. And as Steph said, there are patients who come in within those windows to our stroke centers who have contraindications, don't have a large vessel occlusion, may get antiplatelet therapy, and may be admitted to the stroke unit. When we look at hemorrhagic strokes, again, we know that there are when we look at intracerebral hemorrhage, there is the hypertensive intracerebral hemorrhage. There are hemorrhages related to amyloid angiopathy. What we see with that, sorry, somebody is not muted. If you can just mute your screen. We may see amyloid angiopathy. What we see with those is you have plaques similar to those of the Alzheimer's plaques that deposit on the walls of the artery, cause weakening and cause it to burst. We also may have intracerebral hemorrhages related to anticoagulation use. And last, you sometimes will see a hemorrhagic transformation of a cerebral infarct. This is related to the initial infarct. What happens when you see that is when the clot breaks down, either with TPA and endovascular therapy or as it breaks down on its own, you have blood supply coming into the distal arteries. And because the blood supply has been cut off to them, they become a bit brittle, like a tree in an ice storm. And they come in and you may have a little bit of bleeding. It's not a secondary ICH, it's part of the initial cerebral infarct. Certainly you will see patients who may have surgical, so subdural hematomas, which may be related to anticoagulation use or trauma. Sometimes that trauma may be a number of weeks prior to that. We know we may also see aneurysmal subarachnoid hemorrhage or arterial venous malformations. This slide just summarizes what we're looking for when we look at treatment of intracerebral hemorrhage. And I've just summarized it, what you might see. I'm going to move on for sake of time. So when we talk about transferring patients, we do know, Steph talked about that there are bypass protocols. What we do know, though, is patients, even within that 6-hour window, may go to their home local hospital by family taking them, or outside of that 6-hour window, the paramedics may take them. So what we've built is mechanisms within those centers for ED and inpatients to transfer them for stroke care. You will see here, for those of you at Joseph Red, Joseph Brant doesn't have other hospitals refer in because they service just Burlington, but you will see those are the centers that may come in. So what you may see with that is you may see patients present to another hospital who are transferred ED from one ED to the other. With the special projects, it's the receiving ED that would receive it, and then the patient's admitted to that hospital for ongoing care. You may also see inpatients transferred from a non-TPA hospital to the ED of that TPA hospital. Again, the ED would do that, or we'd look at it, and the sending center would do it. Steph's talked about endovascular therapy and how that works. What that really looks at, and I'll just highlight for you with this slide, is when patients come to the Regional Stroke Center, they are not coming to the ED of the Regional Stroke Center. They are admitted as a DAD admission. So if you are from an ED, you would do the NACRS part of that. When the patient comes to the Regional Stroke Center, we would do the DAD admission. You may see a lot of our patients then are sent back to their home hospital for ongoing acute care. So sometimes patients will stay with us for a short period of time, a couple of days, and then are transferred back to Joseph Brant, the stroke unit, Brantford, for their ongoing stroke care. There are the other reasons we may see patients transferred across are for carotid revascularization surgery. The Hamilton General is the only hospital that provides carotid stenting, but we have 3 centers that do provide carotid endarterectomy: the Hamilton General, Greater St. Catharines site, and Guelph General. And so what does that mean when we look at it is you may have patients who come from an ED to an inpatient unit of that center. They may come from an inpatient bed to the inpatient bed at the Carotid Revascularization Center, or they may be a TIA or minor stroke able to be discharged home, seen in prevention, and then are admitted as we're going. The Hamilton General is the Regional Stroke Center, and so we may have patients who are transferred for tertiary level care, either through neurosurgery, neurointervention, they may need neurocritical care, or tertiary level regional stroke care. So when we look at this, patients may come from an ED of the center, and with neurosurgery, it may be an ED of a non-stroke center who come to those inpatient beds at the Regional Stroke Center. And then once they are stable, are repatriated back to their home stroke center for ongoing stroke care. Steph talked about the inpatient models and how we pull patients from other centers for ongoing stroke care. So how that looks is you may see the patient who comes from an ED of a non-stroke unit to the stroke unit hospital, or they may be an inpatient. So I'll use an example from Hamilton. You may have an inpatient who's admitted with a stroke at our Javinsky Hospital site who is transferred to the acute stroke unit, or in Brantford, someone's admitted to Norfolk with a stroke, transferred to the Brantford General Hospital. In Niagara, someone admitted to Welland, who's transferred to the Greater Niagara General site. I've talked a little bit about repatriation, but really what we look at is really that when patients, because we build a system for acute stroke unit care where we have that expertise locally in our communities, if the patient doesn't require tertiary level stroke care, we would then move that patient back to their home acute stroke unit for ongoing care and management. So we're going back from an acute to an acute. Any questions about that? I know I think I went a teeny bit over time as we're going. There were questions in the chat, but I don't think those were for me, but I was looking. So one of the questions looking at information, so we have, though the majority of our people are from our Central South region, there is a question pertaining to Toronto or Mississauga hospitals. So what we can do, and Steph, maybe I'll ask you to do that and put it in the chat during the break, is similar to the regional stroke network that we have in Central South. There is a GTA stroke network. So the Regional Stroke Center is at Trillium. We also, in Toronto, there are 3 regional stroke networks who all work very close together. Sunnybrook Health Sciences Center, Toronto Western, and St. Michael's, who work very closely together, again, have regional stroke networks and could discuss the symptoms that we could do. So what we can do is we'll put a link to where you may find those in the chat. Thanks, Steph. Any other questions?
And I've put the West GTA link in the chat right now. So if anybody wants to link to it to check it out, you just have to click on that link and it should bring you to it. Amazing presentation, Rhonda. I think maybe it's about 10. We're about 10 minutes behind. So I think if it's okay with everyone, we'll move to our break now. If there are questions that you do have, please feel free to enter them in the chat or maybe even stay on the line right now. But we did want to make sure everyone had a 10-minute break before heading into the second part of this morning's workshop. So if everyone's okay with it, we'll take 10 minutes now and we'll plan to come back at 10 after 10 for the second half of this morning's workshop.
And so everyone can stay on if you just want to mute, and if you maybe want to either leave your camera on or whatever, but you don't need to log off.
So welcome back, and we'll do our best to keep everything on time today. We're very excited for the second half of this morning's workshop. And so without further ado, I'll hand it off to Heather Corrigan and Carla Ariema to walk us through a coder's perspective and really sort of dive into the special project. So Heather, I'll hand it to you to get us started.
Thanks, Stefan. I just want to thank Rhonda and Ellie and Stefan and Carla for allowing a coder to actually have some input in this. Sometimes it feels like we aren't being heard, but you know, when we realize how important we are, and when we have our managers that also like to let us know that, you know, what we do is important, you sort of have to, you know, show up when you're asked. So I want to just say thank you again for letting a coder speak to this problem that we seem to have with not filling out our projects. So I just wanted to start off with a nice little excerpt about how, as a coder, we affect data quality. You know, we can't always blame the documentation for not being there. Sometimes there is some coder error, or maybe even not knowing that it's mandatory, or not knowing how to fill out a project can sometimes stop us from filling out a project that can affect funding. So I just wanted to remind everybody that, you know, we have our standards, we have our manuals, our abstracting manuals, and this really is the basis of the foundation for coders for quality information. So we have some strict guidelines set out by CHI, and as professionals, we are responsible for upholding those standards that we see in our manual, and also making sure that we understand our abstracting manual, taking the time to read what that data element actually is supposed to report. If it is a job that sometimes can be very daunting, especially when you're challenged to fill out so many projects. So here at the General, we have all of the projects that need to be filled out for the strokes, and you know, other hospitals, other acute care sites, even some of the NACRs, they also are responsible for filling out these projects. So knowing what the abstract manual specifies, and knowing what our special projects, the data elements are meant to capture, is part of the challenge that we have. So I put together some slides that, you know, would help us understand some of the problems that we come across as coders for satisfying those special projects. So first, we just want to make sure that we're all on the same page with the common definitions. So we need to make sure that when we read that special project, you know, sometimes the interpretation can change amongst the coding group. It's common. So I just wanted to focus in on some really key points that I found in the special projects that can be confusing. And you know, if you don't read them with a bright mind, or a mind that's really focusing, you can actually misinterpret what's being asked in that data element. So we just want to be consistent, and we want to be sure that we're using the same common definitions. And I think that's part of the job as professionals. So, you know, even within the standards, we have hyperlinks that, send us to the heart and stroke. That's going to tell us what our common definitions are for strokes, for TIAs. Even with Rhonda's slides in the beginning about all the extra terminology that we see in the charts, that was part of the cases that I shared with you, was really just to show how far the language can go sometimes when we read the charts. And then, we can also have the website for Core Health Ontario. It looks like there was an updated website shared in the chat earlier for the CSN network. So I just wanted to make you aware that inside our projects, there's a wealth of knowledge that we can rely on. We also have our e-queries too that we can follow up with. So always staying current with your e-queries is also one of the tasks that we need to do as coders, is to stay current and to share those e-queries with your coworkers. And so I just wanted to remind, we had Ellie also talk and Steph talk about how important our data is. So we are the beginning. We are the ones that capture it. We also submit it, and sometimes we even process it. And just to remind you that the dissemination of this information that Stefan touched on is directly related to us. We may be the beginning, but we are always present again in the end with what the data looks like and what they can do with this data. We need to understand we're part of the public health system here. So, we should be thinking that our work affects stroke outcomes. It's very simple. You can't ignore how important our job is. And I think sometimes we aren't told that, or maybe we just don't feel it. So I'm here to remind you that, what we do is really important, and you should take pride in your job. And, when you have questions, go to your manager, try and figure out who do you contact. So at the end of this Zoom meeting, there's going to be some contacts put out there. So to help you guys try to network in case that isn't available at your site. So they touched on it earlier about the data quality issues identified. So I was able to look at some of the reports that these guys have, and I was actually shocked to see that we have, some sites that aren't submitting at all, or some sites that have like really out of the norm percentage of projects not being filled out. So I was trying to think about like, how can this happen, and why aren't we filling out these projects? I'm only speaking from a coder at the general. I always seem to have the information at my fingertips, so very rarely do I not find the information. Having to look for it is also can be very cumbersome when we don't have the proper clinical documentation, or maybe the chart's missing. So I just wanted to share possibly why are we not satisfying these data elements within the regional health stroke networks. So I just want to remind you that, we know the coding standards, and that's going to drive our code selection. We know the specification of the data sets and what is a valid data entry. That is part of our job. And we also know what the challenges are when searching for the clinical documentation. And to just remind everybody that we are also a wealth of knowledge if we put all of these things in place where we know our standards, we know the manuals, we know the special projects. It's part of our job, and let's do it well, because it affects our relatives who have strokes. It's a trickle down effect here. So I just wanted to highlight that. So what we wanted to talk about was the CT scan within the 24 hours. Sometimes when I go into the project and I read it, I always seem to be like, okay, is it yes? Is it P? Which one is it? Oh my God, I can never remember. So I just wanted to share some notes that I found. Oh, sorry, this isn't the screen yet. So if you've noticed in the special projects field for 340, for the CT scan / MRI within 24 hours, there's a little bit of a subtlety there where the Y takes precedence over the P. So if you want to follow that through where Y takes precedence over P into the next data element, which is our TPA, that's not necessarily true. So the CT scan, the 24-hour window is really the key here on. They want to know if that patient had the CT done within the first 24 hours of arrival to the first facility. So reframe when you look at that this is about within the first 24 hours. Was that CT scan done? Was it done in your ER? Yes. Was it done before he was admitted? Yes. And so I found a really good query. I'm not going to post the query into the oh my God, the presentation, because sometimes we know queries get pulled. So I have a query down here, 78743, where it talks about that transferring, because I think the problem sort of gets lost in translation when we're dealing with, you know, an ER visit, then they transfer them to perhaps the Hamilton General, and then the Hamilton General sends them back. So with that repatriation, here, the yes takes precedence over prior. So yes for the ER, yes for the first institution, and it also yes for the repatriation is yes. So this query really helps point that out, and I thought that that was really key to send across to you guys. Now, the second one was the admission to the stroke unit. We all know that there's designated stroke units. So not every hospital has a stroke unit. You need to understand if you have a stroke unit, it is a group of specialized doctors, physicians, SLP, allied health professionals. So at the Hamilton General, we have a stroke unit. The administration also, next data element, the administration of TPA. So if you notice in this special project, precedent, the pre takes precedence over the yes. So I just wanted to share that. I found that a little bit interesting that here, this is a new share. I'm going to share the special project here.
We can see it, Heather.
Can you see it? Okay. So you can see here the administration of acute thrombolysis. We have these data elements available. You can see here it says yes, prior. They're very clear with their language here, and if you don't pick up on it, you will miss it. They talk about the emergency department or during the inpatient visit at the previous facility prior to direct transfer. So there's some language here that we need to be aware of. And then the yes, this may have occurred in the emergency department or after the patient's admission. And if you go down here, it's talking about record this data element regardless of the time elapsed between the event and the administration. So every acute abstract should have this answered. And I just found a really nice query that I believe Joe Brandt submitted, where they talk about that repatriation. And they're telling you that when you go from, say you went from Joe Brandt ER to Hamilton General for EVT as an acute inpatient, and then you get sent back to Joe Brandt as an acute inpatient, you're supposed to be answering P to this data element. So I'm sure there are other hospitals within our region have the same scenario where you come from the ER, you come to the Hamilton, you give in TPA in the ER, you come to Hamilton, you get your EVT done or any other hyperacute stroke done, and then you get sent back to your hospital. There is an e-query on the website right now that specifically addresses this, and that's how as the repatriation acute care, how are you supposed to be capturing that TPA? So I just thought I'd share that e-query because sometimes, you know, if you're not looking, you won't find it. And also too, I think maybe some people don't realize that when you want to look for project information, you have to choose in CHI that DAD or NACR's abstracting and not in the standards. So if you went and tried to search the standards, you wouldn't find these queries. So just make sure that when you're in CHI, that you're choosing the right data set that you want to look at. So let's just, I just indicate, I want to share just in case.
Heather, I'm seeing that your screen is a bit cut off. I don't know if that's just me. Oh, thank you.
Okay, so this is for any new coders or maybe coders that don't use eQuery a lot. When you want to look for something to do with any abstracting or even our special projects, you want to make sure you choose the topic here. So for the most part, I like to hit my coding standards for most of my eQueries. But when looking for something about special projects or looking about how do you abstract something, just make sure you choose your topic, and you can choose at like 740, 340, 640, you'll get a wealth of eQueries. So I really don't want to talk about what each eQuery says. I just shared two that I thought really address those two data elements that as a coder, every time I come to these charts with transfer in, transfer out, I have to be like, okay, what does this data element want me to capture? So I just wanted to share those two. And also the date and the time of the TPA administration. This is really important to enter. It does trickle down to figuring out door to needle time, best outcomes. It really does affect the QBP, and it is looked at. It is looked at like underneath a microscope. So please try and capture your TPA administration times. And if you can't find that documentation, you still can estimate the day. You can have the year, the month, the day. Okay, so maybe you may not have the exact time, but it should be in your chart. And if it's not getting properly documented, you need to send that up top. That needs to go up top. We also have our anti-thrombotic medications that we're supposed to be capturing. And I just wanted to remind you within the CHI special projects that we have a list of all those medications that we're supposed to be sharing, supposed to be capturing. So, sometimes I have to go, I don't get it in the discharge summary. So then I have to go into medications. Maybe I have to go to the last progress note. I'm not relying just on the discharge summary to tell me. I'm going to go and look. I usually always take more than one spot to look. I don't just take the discharge summary. Oh, they didn't put the medication on there. So due diligence sometimes is trying to figure out where you find that most often consistently in your charts. And then the date and the time of stroke onset. Like, oh, there's so many different things to know. So I prepared a slide for this one because this one is really this is like Steph had said, this was up for quality improvement. This needs definitely some improvement, whether that's a coder's part. We just have to make sure we understand what the difference is between a wake-up stroke. What's the difference between last seen normal? There's some subtleties here. So I just wanted to go into this next slide here. So I saw in the report card, there was a lot of 9999s. It was like, I was like, oh, wow. Like I get some 999s in my charts, but not to this extent. So whether the documentation is different in other hospitals, I have to say we're really lucky here at Hamilton Health Sciences. Maybe our doctors have been drilled into put it in the chart. So possible explanations of why we are seeing a lot of 999s for the time. And maybe the data I was looking at had both NACRS and DAD information in together, so I can understand why you have a lot more of, excuse me, the 999s and NACRS, because some of these charts, there's nothing, maybe the chart's missing. So, maybe there's a project 100 that needs to be looked at when we see all these 999s. Maybe we need to see if some of these charts are project 100s. Also, we have that table that CHI has provided in our special project, where it's that table found of where you can generalize where the dates are. So I just wanted to go back down to this. we have this table here that we're supposed to be using, you know. So when they say breakfast, we don't go 9999. We are supposed to go 8 a.m., you know, late in the evening, last seen well, last night. That when they say we can put in 2200, this is a reliable source that we can use. So you maybe challenge yourself every time you have a 9999 for time, is to look at that chart and say, are they telling us this happened at lunch? Did this happen at breakfast? Did this happen last night? So really start to try and use this, try and get some times into our abstracts. You know, with the chart missing, of course, what are you to do? Like, the Project 100 is really your only fail-safe to back you up on why you're not filling out these projects with, you know, complete information. You know, maybe your clinicians are not good at documenting the stroke and symptom onset. Here, I'll share that again. Or it's missing at the time of coding. Maybe that you know, some of these charts where the stroke symptom onset isn't even being documented because it was misdiagnosed on arrival, and it wasn't only until the DAD chart was completed that they realized that, hey, this patient had a stroke. This should be a small percent of what we're seeing, but according to the report card, we had some hospitals that were quite high with 9999 coming across. So I was even at our own hospital, the numbers were high, but I was like, okay, wait a minute, 999 is a valid, you know, it is valid. It is to show that either the documentation was lacking or the patient had no idea. So they were unconscious. So they don't know what time. So maybe just the date and year and month is all we have. And that is acceptable. I just wanted to challenge us again to make sure we use all the tools that we have with these special projects. So reviewing some of the elements collected in the CHI Special Project 640, you know, the dysphagia screening for us at the general is sometimes really hard to find. But I just wanted to remind everybody too that with the screening for dysphagia, that the number 8 is actually valid. So when you have somebody who's intubated or whose decreased level of consciousness where they're unconscious, you know, there is reasons why we use number 8. And I just wanted to review again that, move this over, the Special Projects 340. These are all the applicable, you know, this is all valid data. We can see this. So, you know, 8 is for not applicable. And you know, I think sometimes we forget to remind ourselves, you can see here that 8 will tell us that the patient was unconscious or on a ventilator or incapacitated, you know, and maybe they died. And so dysphagia screening never came into play. You know, for the most part, we do have the SLP coming and seeing our stroke patients. I even read some of the ER discharge documentation where the nurse has trialed a swallow test by sipping of water or taking medication. So really scouring your ER, you can usually find that even before the patient is admitted for some of these strokes. They know what to look for. This is really important that we capture that the swallowing assessment is being done. It can be done by a nurse, it can be done by the SLP, it can be done by anybody who is documenting in that chart. It doesn't have to be an SLP allied health professional being the only one doing that. So I just wanted to remind you that sometimes when we have our ER admits, you'll find that they'll challenge them in the ER with taking a sip of water. Getting that documented in your ER, you really need to ask that gets put in there. And so for the 640 as a DAD coder, I was really unaware of that emergency room triage date and time and entering that. So I can't really speak to that, but as a NACRS coder, if there's anybody here that's coding NACRS, this is really important too. You need to take the time to fill this in. just wanted to see what's chat. So next slide. So when I was reviewing this Y alpha FIM, the 740, there's a couple hospitals that don't do 740, like 100% non-compliance. So I was a little bit shocked because it is mandatory. It is a mandatory special project. The only exclusion is the neoplasm for most of our acute. So we don't have to fill out 740 if the patient's care is all ALC, so rehab, even in acute care with an ALC from the very beginning. Okay, you don't have to do it. And the neoplasm, that excludes you. So some things that I learned also preparing for this is that I know personally that sometimes the scores don't fit into the allowable time. So maybe the score was, recorded improperly. So you just want to make sure that when you have a raw missing, like a missing raw cognitive score, and maybe you have the raw motor, you can enter 99 for one of those scores and then continue to fill out the project. What I found also important is sometimes I've found that at our hospital that maybe the score gets entered after discharge. So it's a day or two after that the therapist was able to enter the score. I found an e-query that says when this happens, capture that it was done and use your discharge date. So I thought this one for me was important to share because before I would have said no to this project because at the year-end quality data edits, it would come back to me saying this score doesn't, or this date doesn't fit with your admission. So I would then just say no to the project. Well, now it says we have direction that you can use the discharge date when your alpha FIM score is reported as a day or two after the fact, because what the query says is that somebody did see them. Somebody did assess them in your visit. Default to the discharge date if that time does not fit into your admission visit. So I thought that was a good query to share. Next slide. So I couldn't figure out why we were having so many alpha FIMs not even being reported. So I just want to let you know, N is valid. So if you have no assessment, alpha FIM assessment done, you answer no. You just don't omit the whole project. So, not validating the alpha FIM project because no one is qualified to enter the scores is not, you need to answer no. It's not, you just don't, don't omit the whole project off of your abstract. It needs to be collected with 340 and 640 and 740. So answering no can solve a whole bunch of these questions. And, there's an important part too, is that when I looked, it tells me who's not filling out the 740 by our LIN, by site. And everybody in here had 25 cases or more. So if you have 25 cases that have a qualifying stroke code, you have to be doing 740. Whether you answer it with a no or a yes is then the next part to it. So if you don't have somebody filling out the scores or that is trained to do that, you answer no. The only time you don't have to do the 740, I think in our group here is that brain neoplasm. When the stroke is associated with a brain neoplasm, that really is the only exclusion. If you have a stroke code on your chart, you need to be validating this project. So like two strokes a month, and even if your visit is short, less than 3 days, that does not mean you exclude this project. The inclusion is the code, not the length of stay. So I just wanted you guys to be reminded of that. Sometimes it's hard to decipher, is this included, is it excluded, doesn't fit the regular box here. So I just wanted to share that with you. So I'm going to have a polling question here just to see how many of you, how many of you have stroke codes that are due just most majority of neoplasm. So Steph, if you could just get this polling question out there just so we can see. Oh, thank you.
Heather, I'll give it about 20 or 30 seconds. Still getting some participation here, so I'll give it 5 more seconds. Okay, it's slowing down now, so I'll end the poll and I will just, you want me to share the results? Heather, put them up on the screen?
Sure. So yeah, you can see what I wanted that poll to show is that, like, really the only exclusion in 740 is that neoplasm. So whether you're short, whether your length of stay doesn't qualify for the 3-day, that doesn't mean you don't capture 740 at all. You just answer no. So I think that's one thing that we can at least all agree on, that maybe there was some misinterpretation on what qualifies for 740. And every query that I read said it is the same inclusion as 340. So I just wanted, to point out that I was kind of shocked to see that there was some hospitals not partaking across the board in filling out that alpha FIM. So maybe we should challenge ourselves again to drill down and look at what was the decision on why we weren't filling this out. And then the next polling question is to maybe fill, how are you capturing that repatriation? How are you coding that? Are you coding that to convalescence? Are you coding that to ALC? Are you coding that to stroke? This may be helpful to understand why some of these alpha FIMs aren't getting captured.
Lots of answers coming in right now, Heather. I'll give it another 20 seconds or so. Okay, it's slowing down, so I'm going to end the poll and I will display the results. Oh, a few more last second ones coming in here. Okay, I'll share the results. Can you see them there, Heather?
Yep. So I can see there was a couple of convalescents. I think, Rhonda, I was just wondering if you could just reiterate again on what as a ALC navigator again, what code should the hospitals be using? Because I understand for the way you explained it to me, the Hamilton General, we're like a hyperacute stroke center, so we do the tertiary care. But when we send them back to their community hospital, the stroke care is still continuing. Am I correct in saying that?
Yes, yeah, that's correct, Heather. There may be situations where, and these are, if we look at the 80-20, most of the time these patients are going back to acute stroke unit care at their sites. There may be situations where if the patient's palliative, they may go back to sort of a palliative unit at that center. But usually those patients are going back to acute stroke unit care to finish up maybe their workup, to determine if they need rehabilitation, and then determine what their ongoing needs are.
Okay, so I just wanted to touch on too, since I'm asking this question just to maybe further understand why our 740s are being ignored. So even when you have convalescents, you have to still, a mandatory 3 is to list the diagnosis that they are convalescing for. So your stroke code would still pop up as a 3, and then you have to do the stroke projects. So like Rhonda said, very rarely do they go back as ALC, which would be one of the reasons why 740 would not be captured. So for the most part, when you're getting somebody sent back from our EVT procedure, they are still in acute stroke. So it's just also all those projects then need to be validated. So just a reminder on that. So just to touch again on the EVT population, I just wanted to double check. Stefan, can you send this poll out too?
Responses are picking up now, so I'll give it another 20 seconds.
Okay, that's good to know. So I just wanted to clarify, because I think sometimes, you know, as coders, we don't know what facility they're going to when we set as general. We don't know if you're going, sometimes what site they're going to. Are they going to your general rehab? Are they going to your acute care? And I think too, as NACRS coders, you don't know what's happening sometimes on the end. So I just wanted to use this poll to show that with EVTs, specifically to EVT, we at the general have really streamlined this, where at the beginning, maybe they were coming through our ER, but Rhonda's team has made it sure that they are coming from the NACRS institution, from the community to the DAD. They are coming to the Hamilton General inpatient bed right away. So when you're doing that NACRS abstract and they're coming here for an EVT, you have to fill out your project 640, because you're coming to an inpatient institution and you're the prior facility being the NACRS. You are responsible for capturing those projects. So I just wanted to show that, you know, sometimes we don't know. So 30% of us are still using the NACRS institution when they're coming to our department. So.
And Heather, just to flag, I did put it in the chat, that is the process in Central South. What I would flag to those that are from outside of Central South is that is sort of a unique process that we have in Central South. Other parts, so in the GTA in Toronto, the patient would go from an ED to an ED, so a NACRS to a NACRS. We've streamlined that process in Central South. So just be aware and look at where they're going.
Okay, well, I guess the 30%, yeah, I don't know where those 30% are. So just to clarify again, thanks, Rhonda, that within our stroke regional network that we have streamlined this process. So that might help some people better understand what that flow of patient looks like for us. So there's some time here for some any questions. I don't know if there's been anything going on in the chat, but if there's any questions that anybody would like to put in. If not, we can come back to it. If you want to put it in the chat and then somebody can read that and validate the question. We can.
Is a question, Heather?
Okay.
Heather, it's me, Karen.
Okay.
I think I know the answer to this, but I just want to ask, when doing a stroke chart, looking for this symptom onset, if you have last seen normal and you have stroke symptom onset, last seen normal takes precedence because you don't know when those symptoms truly started, correct?
Well,
is that correct?
I don't want to make any blanket rules, because again, each chart you have to really challenge yourself on stroke and symptom onset versus last seen normal. So you would have to get it sort of like how Kai says, what's the scenario? So it's hard to answer that when you don't have the chart reading the chart. So I don't want to say which trumps what, because it really depends on the context of the chart that you're reading. So it's not that I'm skirting it. It's just I've learned that, you know, making. No,
I think I read a query once though that said they went to bed normal. Okay, they went to bed normal. So 2200, let's say, and they woke up in the morning with the symptoms. So you truly didn't know at that point when those symptoms really started, correct?
Yes, so Heather, if you're okay. So great point, Karen, and great question. So what we tend to do with symptom onset is if it's witnessed. So if the note says husband and wife were eating breakfast at 8:30, wife noticed husband had stroke symptoms, but when he woke up, he was normal. If they went to bed and they were normal, they woke up with symptoms, you would use last known well, because we don't know when the symptoms happened. Conversely, if say family left in the morning to go to work, patient was normal, came back at the end of the day, found the patient with symptoms, you'd use last known normal. Sometimes we see in the charts, which is with the paramedics, is they'll say the patient went for a nap at 1 o'clock, woke up at 4 o'clock with symptoms. Really, that last known well would be before they went for their nap.
Okay. Okay.
Really, it's looking at really moving to that last seen without stroke symptoms really is helpful. And we've reinforced that with our paramedics.
Okay. Thank you. Thank you, Heather.
Heather, there's another question in the chat here. I can read it here. When transferring to 51982 for NACRS P-340, how should we answer referral to stroke prevention and prescription?
This is for the NACRS abstract?
Yeah, it looks like it's for the Project 340.
This is something for I am not a NACRS coder, so let's just pull up in 340 NACRS. So this is the data, referral to stroke prevention services at ED discharge. So there was a really good query about the Telestroke, not knowing when to satisfy for Telestroke, and they do not assume. So there is no documentation that confirms an appointment was made or that the patient was given a referral for stroke prevention service prior to leaving the ED department. So you would answer no, because you don't, on your ER visit, he's being transferred elsewhere. He's not being discharged home. So sometimes, you know, your stroke projects, you just have to remember that you have a certain snap time frame. So you can't answer what's going to happen in that data abstract. So your answer would just simply be no. Within your visit, there was no referral. So sometimes it's hard to reframe how you're going to, you know, abstract. So ER NACRS is like when they leave that ER visit, you cannot guess or assume what's going to happen in the next facility or in your admitting facility. You can only capture what's happening in your visit. So all you know is that they were transferred out. So no, there was no appointment given in your ER visit at that point in time. He was transferred out. So I hope that helps clarify that. It's hard sometimes to reframe which data element you're trying to capture. And so reading it over and over again, sometimes, you know, you can get something out of it. So what I've learned is don't assume. And if it doesn't happen within your visit, it doesn't happen within your visit. No, it's just a simple no. Is that correct, Rhonda? I believe that's.
Absolutely, Heather, because again, they're going to another acute facility. They may get prevention after the fact, but in this episode of care, they're not. And the same with the prescription. Again, often if they've gotten TPA or not, it would be a no, because again, they're going to another facility where it may be there. And a great point, Heather. You document what you see, and again, they wouldn't be getting it in that situation.
So this is the part for the coders that I apologize now for the charts I chose. There was a reason to my madness. So I apologize that if it was frustrating to figure out what to code. So what I just wanted to.
Heather, just one thing, your screen is cut off. So maybe if you just want to share again.
Thank you. So here we go. So the stroke and symptom onset time. This chart was very clear with the stroke and symptom onset, the ambulance, the ER triage, repeated numerous times. So the stroke and symptom onset wasn't really the issue that I wanted to highlight here. It was more about the code, the stroke code. And I think, you know, sometimes when I'm coding, I think, can they ever tell us exactly what kind of stroke this patient had? And, you know, as to Rhonda's presentation, that, you know, there's 30% of our ischemic strokes are cryptogenic, where they just don't know it. Sometimes you can't diagnose it in our small visit time. So, you know, sometimes maybe I63.9 is our best fit code. So I just wanted to continue with the next slide here. So the stroke diagnosis following the documentation within the chart, I just wanted to highlight that sometimes in our charts, and I'm only speaking about the general charts, is that, you know, many clinicians, many hands in the pot, you get lots of different terminology thrown around. And so I just wanted to highlight what it is for us as coders as a challenge for our stroke code, and that maybe if there's some clinicians listening to follow up on the force to help, you know, give some specificity to these codes. So we had one doctor called it small vessel disease, that goes to lacunar infarct. Another one called it ICAD, which is intracranial disease, which, remember, part of the intracranial is pre-cerebral and cerebral. So still a diagnosis of ICAD generalized does not give us a specified code. We are left to 0.9. There was also artery to artery disease documented, and that means like a thrown clot. So a clot developed in one artery and then transferred to another artery. So that would be almost an embolic code. And then again, they talk about plaque rupture. So the thrombus was dislodged. So you can see that within the chart, we can be all over the map with codes. And sometimes it's that final discharge summary is really where they're supposed to nail it home for us and give their final, you know, final thoughts. So I just wanted to share this chart here that, you know, you can say that they will start to look for certain things to rule out. So the whole process is ruling out before they sometimes can get to the final code. So that process sometimes can be mind-boggling as a coder trying to read that. So just remember, they're always trying to rule something out in order to end up at their final diagnosis. So I just wanted to note that our final diagnosis for this chart obviously is I63.9. They're only telling us it's an infarct of the pontine. Now, if they said pontine artery, which there are pontine arteries, but they are talking about the pons. They're talking about the pontine. So he had an infarct into his brainstem. They're saying it's likely secondary to a plaque rupture. So you can see in this discharge summary, I just wanted to highlight likely, everywhere in this discharge summary, very likely. So, you know, I don't know if this is true at other sites, but we have a lot of residents. This is a teaching hospital. And unfortunately, the discharge summary is tasked sometimes to the medical student or to the resident. So, you know, are they not sure with their language? Or really, is this stroke not being able to be identified to any specific cause? So sometimes our challenge is the resident not sure of himself, but when we can only use our diagnosis where they're saying it's likely to a plaque rupture, we have our, you know, unconfirmed diagnosis standard that we have to apply. Whenever they use the term likely, you have to code to the unspecified, so I63.9. So we could have captured possibly an embolic stroke here, but still we don't know what artery was occluded to cause the stroke. They don't tell us the artery here. Very rarely at the general do they tell us that. So this was just sort of an exercise to show that at the very end of it, sometimes we are only left with one choice, and that's I63.9. And there may be more information that maybe we're not privy to. Is there something, Rhonda, you wanted to say
I was just
something?
going to say, there's a comment in the chat. Isn't it saying that the cerebral arteries were the ones involved, but not 100% sure of the type? So I-63.5.
Well, actually, they're also talking about, the M1 and the M2. They're also talking about the vertebral. So again, in the chart, he talks about both pre-cerebral and cerebral arteries being occluded or having high arteriosclerosis in it. So you can even say here, it's saying the supraclinoid aneurysm likely. So even if he's saying it's likely, I couldn't even find in the MRI or the CT them specifically saying which artery. So again, do you go with one versus the other? We again have our unconfirmed diagnosis that, you know, they aren't specifying if it's a cerebral artery or a pre-cerebral artery. We still have to default to 0.9. So I chose I-63.9 because he used the region of the brain. And even if he said it was likely secondary to plaque rupture, what artery was occluded? You have to tell us what artery was occluded. You're telling us numerous arteries here are occluded. I can't code occlusion of a pre-cerebral artery and a code for occlusion of a cerebral artery, because then that would show the patient had 2 infarcts. So he only had 1 infarction. Which artery caused it? I think at the end of this visit, I personally did not have any clear documentation that they were pointing to one towards the other. So again, back to he called it small vessel disease. He called it ICAD, and not he, but many. These are many different physicians that coded, that documented on this chart. So I ended up with I-63.9.
Heather, there's another comment in the chart, I-63.8.
No, because you need to specify. I-63.8 has direct links to hyperperfusion, watershed. So I-63.8 actually refers to specific types of stroke. It's not a catch-all. It's not to say that he specified it, but it wasn't elsewhere classified. That doesn't apply to this. There's a screen I'll show later on about what I-63, you only use I-63 in specified circumstances. You don't use it to catch all the stroke codes that didn't fit into these boxes. Each code at the stroke code is very detailed on which strokes belong into which. So hopefully everybody else was challenged with the fact that this likely, and if he says likely, that means he's uncertain that it was due to plaque rupture. So still, what artery was occluded that caused this pontine infarct? It could have been numerous arteries in different levels. So sometimes it's really hard to pick out which one. So I just wanted to see if everybody else out there has the same problems of the coders at the general. So Steph, if you wanted to put this polling question out.
Lots of answers coming in for this one, Heather, so I'll give it another 15 seconds. Okay, starting to slow down now.
So I can, okay, good. It's good to know that this is a common theme here, that word likely or presumed or questionable ends up in our discharge summary. And you know what? 30% of these ischemic strokes, they don't know at the end. So maybe then using the term likely seems to be a common occurrence here. So let's move quickly. So this is a message to the stroke teams that are watching, to, you know, that we have to apply an unconfirmed standard when you use likely or probable or presumed in your final diagnosis. That means you're uncertain. So we have to default, not always to I-63-9, but default sometimes to the etiology. If you tell us which artery is blocked, we can at least default to a code in I-63 that focuses on the artery, but then we miss out on embolic and thrombotic when you use the word likely. So let's quickly move to the next one. The next chart. This chart was interesting. I just wanted to quickly note that symptom, sign, and onset. So Karen asked this sort of approaches to use that. At first, they noticed at 9:30 that the patient had some speech problems. Then questioned further. Maybe it started at 9:15, and then the wife finally came into the ER and into the was actually able to speak. And then she wasn't too sure that actually she spoke to him after he woke up or when he woke up. So it was actually then becoming a wake-up stroke, is because his speech disturbances were present upon wake up. So there was documentation within the chart here. Oh, sorry. Where it said the stroke doctor actually made an addendum and actually talked about this in the consult very clearly, right here in the highlighted portions, that at first when they came by the ambulance, they said 9:30, and then talking in the ER 9:15, and then further questioning, the wife was not sure if he actually was normal on his wake when he woke up. So it gets put back to wake up. And so I just wanted to let you know, on a wake up stroke, there is an e-query that we have that says you can use 2200. So if they don't know what time they went back, if they don't know what time they went to bed, you can default to 2200 hours. So that is why I had it set at 2200 hours, is because last night, so before he went to bed, 2200 hours, there is an e-query. I, for some reason, didn't put the e-query number down. But there is an e-query about defaulting to 2200 hours. I will get that e-query put into the project, into this presentation, that you go back to wake up stroke for this guy. And then also, I just wanted to highlight again the problems that we have as coders. This is the final discharge summary: left thalamic and posterior.
You're not sharing your screen.
Oh.
As you're calling that up, just to let you know, there's about 4 minutes left.
I don't know where it happened there. It's not showing up on my share screen here. Jesus, here we go. So again, we were all over the place with these codes. If you wanted to try and code every time the physician said something, but again, if he only listed the region of the brain in his final diagnosis, and when you have only the region of the brain listed, Chi-High is pretty clear. When you have an ischemic stroke, if they only tell you the region of the brain, you go to I-63-9. If you have an ischemic stroke, they have to tell you what artery is occluded or stenosed in order for you to even get to thrombotic, embolic. So, you know, sometimes our challenge is you can tell us it's cardioembolic all day long, but if you don't tell us the artery that has caused the infarction, we are still left going back to I-63.9. And I think that's here further to that I-63.8. You can see that I-63.8 is reserved for specific codes within our infarction. So you can't use I-63.8 to capture all the other stroke languages that you can't code to. They're reserved for specific codes. So I just wanted to point that out too. And then in case 3, they told us at least what artery was occluded. So here, we probably won't have time for this polling question, but I just wanted to point out that at least in this discharge summary, they told us it was an MCA stroke. So there is a query when they say MCA in the title, assume that that's the artery that's occluded. It doesn't say MCA territory stroke, it says MCA stroke, and CHI is pretty clear that assume thy artery is occluded. So at least we had I-63.5, a cerebral artery was occluded. And then I found that this documentation was really important too, is because he uses the word thrombus, he talks about occlusion, but then the etiology, what they believe at the end was due to a PFO. So if you have a thrombus and a PFO, you aren't coding to thrombotic stroke, you're coding to embolic, because that thrombus then leaves the heart and then travels to the brain. So once that thrombus is on the move, it's no longer thrombotic, it's embolic. And I think a lot of people get stuck on that word thrombus, occlusion, thrombotic. No, still take your context of the chart to understand the etiology of it. So I found this chart really interesting because they use the word thrombus, they use the word occlusion, but really they thought it was a PFO, but again, he used the word likely in the discharge summary. You can see it was likely due to a PFO. So again, unconfirmed diagnosis we have to go back to, but at least at I-63, he tells us the artery, so we can go to I-63.5. We know the vessel was occluded. He tells us the vessel was occluded with a thrombus. How that thrombus got there, they're still not too sure of, by the way that they've dictated this discharge summary. So I just wanted to say, you know, a coder's challenge is to read all the diagnoses within each chart. We have CHI's job aids, we have e-queries on top of the standards. We try to cover as many they try to cover as many scenarios as possible, but we know, like, the language used within charts does not always fit into the boxes that CHI gives us. And we have codes sometimes, but we cannot use them if we are not talking the same language as the clinicians. And I think that truly is the coder's challenge, is for clinical documentation, is what are they saying? Because we have a classification system, but sometimes we can't get to the code because they aren't specifying it for us. And that's the end of my presentation.
Thank you, Heather. That was a great presentation. I think it reflects how important we are as a coding team across the province. So thank you very much. That was excellent. I'm just going to quickly talk, I don't have slides, about strategies to improve data quality. I just have a few points that maybe you can try at your sites to improve data quality in this area for the stroke program. We all connect with our clinicians, our wonderful team, Rhonda and Steph here. They are amazing. They are a fountain of knowledge to liaise us with the physicians and to get that message across what the documentation should look like for us. So we marry the folio language with the clinical language. So I do suggest you seek out that group, that clinical team at your site if you have one, and it makes for a robust process. We collaborate monthly, quarterly, yearly. We do reconciliations, we do validations on EVT indicators, the QBP strokes, making sure they are included. What we're coding is falling into the QBP cohorts. So that's very important to have that relationship with your clinicians. It won't work one-sided. We have found out in the last few years working closely with Rhonda, Steph, our decision support advisor, who's close to this stroke program as well. They are the key to, with the coding team, to improve data quality strategies. So that's one. I also suggest you leverage your software, your coding and abstract software. There's project links attached to the ICD-10 diagnosis code tables only. So to each applicable stroke condition, you can attach a project link default, which will prompt Dan Knacker's coder. Unfortunately, there's only one ICD-10 diagnosis table for the whole software. We are in Med 2020. You can be in 3M or Answer or whatever system you may use, and seek out with your vendor what you can do to link some projects, to prompt your coders, to remind them. Unfortunately, you can only link one project. I chose to link the 740, as Heather said in her presentation. It has the least exclusion criteria, but you can pick whichever one you want. And at least it prompts, it's a yes or no question or a cancel out in your software. And it is a nice prompt for the coder, because we have to know so much in a chart and go into so many resources. So I think it's a nice tool to use if you can leverage your abstracting software that way. We also have purchased the edit management tool here at Hamilton Health Sciences that allows a user to create their own edit specs. So I can prompt the coders to say, hey, you have an applicable condition here. Don't forget your 340, your 640, and 740 if applicable, etc. So that would come down in your error window. In WinRx, it's down at the bottom, or however your system works. So that's another area to explore to improve data quality. And the last one is your open year data quality reports from CIHI. Please don't forget to launch those from your CIHI services. They just published the quarterly reports this week. So it's every quarter. They come out, have someone in your data quality area of your hospitals, send those to the coders. They have Project 340 test specs. They prompt you for the 640s. So there's lots of opportunity on our side of things to make an effort to improve our data quality. I work with Rhonda, sends me 340 and 640 right from the clinician's desk on what she found an SLP did for dysphagia screening. So we work very closely with the detailed aspects of each project question. So I hope you can leverage all of that in your facilities, and I think you will improve your data quality for the stroke program. Thanks.
Thanks so much. Any questions for Carla? So I'll share my screen just to finish up. Sorry, as I look. So I'm going to stop sharing this. I don't know why it doesn't want to close the other ones. All right, so wrapping up. Oh dear, this is doing it again. I think, do you only see half of my screen?
You can see most of it, Rhonda.
Yeah, you're okay.
All right, let me just stop and I'll start again. I don't know why that does it. Sometimes it goes great, sometimes it's challenging. All right. So I pulled up the wrong one. Sorry, guys. What we did and what you will see posted is we did create some key contacts for centers so that you will then see in the presentation. I'm not going to go through it today. Close this because whatever I do doesn't want to pull up. So what we did is we included some of those the links and resources. We also provided you a list for our clinical contacts so that then you will have those, but I'm not going to go through them. One, for the sake of time, and I think many of you already have your links there as we're going. What I'm just going to share a little bit as we go forward is some of the things that you may see changing as we move forward in stroke care. In the short term, some may be a bit more in the long term. So what we talked about, as Steph talked about, is we know the paramedic prompt card takes patients to the closest stroke unit. In January, of 2021, the paramedics added the additional of the LAMS tool. So you may see that in the LAMS documentation or in your ED documentation. What that is a screen for large vessel occlusion strokes. And what a score of 4 or 5 indicates is the patient may be positive for large vessel stroke and may benefit from endovascular therapy. Currently in our region, patients, the paramedics will still take them to the closest stroke center. What we may see once we do a bit more analysis to get a sense of the impact of volumes is perhaps not all across our region, but you may see, similar to what you may see with cardiac procedures and taking them directly to the heart investigation unit, is we may see patients from the field who are positive with the LAMS coming directly to the regional stroke center. Probably a while away, but you may see that coming down. The other thing, I think we'll likely see this shorter than later. So I talked at the beginning that TPA, alteplase, was the primary thrombolysis agent we used. We have been doing studies over the last period of time as we're going, using and testing tenecteplase, which is a one dose, a single bolus injection for TPA. Studies are showing that it's as effective, it's safe, it improves outcomes, it may provide better opening of the vessels for large vessel occlusion strokes. There's a large multi-center international trial that's just analyzing data. So we may see a shift in the near future, maybe even in a year, to having tenecteplase be the agent or TNK for thrombolysis in your emergency departments. The other thing we may see, typically when we look at TPA, it's within 4.5 hours there, and typically patients have an NIH of 4 or more. There are trials looking at patients with mild strokes with TNK that we may see up to 12 hours of onset of symptoms may be safe. So what you may see is sort of TPA or TNK being used in broader windows. The other shift that you saw, and we saw that with endovascular therapy in the 6-hour window, is we typically have used time. So when were they last known well as a proxy measure of how long that brain tissue is viable. What we do have though with CT perfusion software, which all of our thrombolysis centers in our region have, we have the ability to look at the perfusion of the brain to determine is there viable brain tissue that we can save with hyperacute stroke therapies. So what you may see is thrombolysis windows being expanded using patients with CT perfusion up to 4.5 to 9 hours, wake-up strokes, patients with unknown onset. And what they're finding is what this software is showing. So really the pink is dead areas of brain and the green is viable areas of brain. What it allows us to do is really look at the brain at a pinpoint in time and say, this patient has a lot of savable brain. It may be, as we talked about with wake up or unknown onset, that actually the stroke may have happened sooner than it is, but there's viable brain tissue. So you likely will see that changing also. The other things that we may see is we may see, because of we know endovascular therapy is such a powerful treatment. We know that you only need to treat, it's about, I think, 4 or 5 patients to really see one patient improve. And so because it's so powerful, we may move beyond sort of our current exclusion criteria to patients who have more damage on the brain, which is identified using the aspect score. You may see patients who maybe they have a low stroke severity or NIH, but they have a clot. Right now, we don't know what to do because if I have no stroke symptoms, but I have a clot, do I go in with a procedure that may cause me to worsen, or we know that that patient may worsen. So we may see pieces move forward with that. The other thing that we may see is new anti-thrombotic agents for patients to prevent stroke. So one of those is ticagrelor, and looking at with TIA or minor stroke, giving ticagrelor and aspirin significantly reduce the risk of stroke and burden of disability at 30 days. So what you'll likely see, and as Heather said, there's listing of those anti-thrombotic agents. You certainly may see that expand and moving forward as we go forward as there's further research. One of the things that I will say that you might have seen in some of your charts on patients who have a TIA or minor stroke, you may see that the physicians are ordering dual antiplatelet therapy with them. There's evidence in patients with TIA or minor stroke that aspirin and clopidogrel or Clawback for 21 days reduce the risk of recurrent stroke. So you'll likely see things changing as the evidence progresses. Any questions about that before I wrap up? So you should have received already an email that gave you a link to complete the evaluation, and I had put it in the chat earlier. Please do take the time to provide your feedback. We really use the feedback from our evaluations to inform planning of future workshops. If there's other topics that you would like us to address, please feel free to provide that feedback. Also, I have an email ready to go to get a copy of your certificate for your CMEs. So once this finishes, I'll send that off to people. If you don't receive it, just email me back. And again, the last thing I would say is you will receive an email in the next week or so once we get the presentations and the recordings uploaded onto our Central South Regional Stroke Network site. But I have included the link to the resources, www.csnstroke, which will take you, if you go to the health professionals, the link to the presentation. Heather, you have a question?
I got a question. Just to let you know that I found the eQuery number for the default to 2200 instead of using 999 for that one case. I have included in the notes of the presentation. So if you could update my presentation, it will be included in that.
Thanks, Heather. And so I just want to thank everyone for participating and contributing. We've had over at any point in time, I think we're at 138, 140 participants, and we've had 135 stay to the end. So thank you so much. One of the things that we talked about as we were planning this workshop is this is actually a bit of a COVID bonus. And in these day and age, there isn't lots of bonuses related to COVID, but we're really able to provide an opportunity to a great presentation. We can capture people in a broader area. And so thank you so much for taking the time from your busy days. Thank you so much for the great work and the hard work you do. Again, working in stroke, we are so data driven with what it's doing. And I think your role is so important, and it's important, one, with the excellent coding you do, but I think really important with flagging, if you're not seeing the data completed, reaching back to your clinical team so that they can go and do the deeper dive. For example, Heather talked about, that alpha FIM not being documented, even though it was done the day before or 2 days before, not documented until after the patient was discharged. That's a simple fix that we can link back to our teams to do it. So thank you everyone for your time. And we really look forward to your feedback. Have a great day.
Thanks, everybody.